One of the biggest misconceptions out there, and I can say misconceptions because I'm educated to know it's not, is that vaccines cause autism, but that is not true.
Vaccines do not cause autism.
Why do we know that? I want people to hear this. Why do we know that vaccines don't cause autism?
The best researchers in the field and in other fields have looked at it and ruled out an association between receiving a vaccine and triggering autism.
There's been not only no evidence, but there's been so much negative evidence, right? You can't prove a negative, unfortunately, right? And it just is puzzling why it persists.
For the same reason, lots of things persist with people. They just get stuck on it. Hi, and welcome back to The Vitals, Mount Sinai Health System's groundbreaking podcast. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. Today, we're taking a deep dive into autism, what we know about its causes, how it presents across different levels of severity, and how access to care and treatment vary widely. We'll also explore the difference between childhood and adult experiences, comorbidities such as epilepsy, and the current state of policy shaping autism research and treatment. Joining us are two of Mount Sinai's foremost experts in the field. First, we have Dr. Avi Reichenberg, Professor of Psychiatry and Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai, and the Director of Population Research and Environmental Epidemiology Program at the Seaver Center for Autism Research and Treatment. His groundbreaking research has advanced our understanding of autism's genetic and environmental risk factors. Next, we're joined by Joseph Buxbaum, Professor and Vice Chair of Research in the Department of Psychiatry at the Icahn School of Medicine at Mount Sinai, Director of the Seaver Autism Center for Research and Treatment at Mount Sinai, and a leader in genetics and neurobiology of autism. His work focuses on translating cutting-edge research into targeted therapies and improved patient care. Thank you guys both so much for being here today.
It's a pleasure.
Yeah.
Thank you.
So this is definitely a topic that everyone talks about. A lot of people that actually don't know what autism really is, and a lot of people who thoroughly know what autism is. So I'm excited to finally get it all out here today. So before we kind of get into the science of it all, would you mind just kind of defining autism in the most simple terms that you can?
Sure. So autism, the diagnosis of autism relies on two criteria. The first is deficits in social interaction and social communication. And the second is the presence of repetitive, restricted behaviors or interests. And so you have, on the one hand, social deficits, on the other hand, a focus on things that maybe seem a little bit out of the ordinary.
Are those things that you can follow on guidelines that are written on paper, or is that up to whoever is doing the evaluation?
So there are very formal guidelines called so-called DSM guidelines, and they're actually codified in assessment tools where you can actually measure multiple things, ask questions about interest, you can ask questions about social interactions and so on, and you can actually get a score at the end of the day.
Okay. So that's kind of, once you hit a certain score, you know that you're giving that diagnosis. Where are we today at understanding the causes of autism?
So we're actually very good about understanding general causes. When we think about causes of a disease or a trait, in broad strokes, we could talk about the environment, we could talk about genetics, we could talk about other things like that, and we can estimate the relative contribution of major factors. In the sense that, for example, a genetic disorder looks different than an environmentally caused disorder. A genetic disorder, by definition almost, is going to be more similar if you're more genetically related, right? So twins, identical twins that are fully genetically related, are going to look exactly the same. That tells you that the way we look is genetic, right? Mm-hmm. As you get further and further away from your relatedness, if you go through, fraternal twins, siblings, first cousins, you look less and less alike because that genetic sharing is going down.
Right.
So genetic disorders have a very characteristic footprint, if you will. Conversely, so do environmental disorders. If things change based on culture, geography, smoking versus non-smoking, right? It's pretty obvious, right? So we don't have to actually know what part of a cigarette causes cancer, lung cancer, to know that it's actually caused by environment. And it's also true for genetics. We can say something is largely genetic even without finding the specific genetic cause. So we've come a long way, a lot of critical work over decades, a lot of groundbreaking work by Avi Reichenberg as an example, showing that autism is largely genetic. And the breakthrough most recent breakthrough is we're finding the actual genes. We can
Right.
come back to that later. Maybe that's a good idea.
Okay. But, well, before we get too far, now you guys are going to hate this question, but before we get too far into like the medicine and the science, there's a lot of shows out there on television that that go over and have actors or documentaries that have people that have autism or on the spectrum. There's a show, it's my daughter's favorite show. It's called Love on the Spectrum, and it's a dating show for autistic people. There's also a show, Atypical. Rain Man was a movie from the past. Community. Do you guys watch these? You know what I'm talking about?
Sure.
I watched Rain Man.
Okay. Yes. You're like, but have you seen Love on the Spectrum? You know what I'm talking about? that
I
one?
know what you're talking about. I haven't seen the show.
Okay, so let's just go with Rain Man.
Okay.
Was that an accurate portrayal of autism?
Of severe autism, I think it was a good portrayal of one more severe form of autism.
Okay, yeah, because like when I watch shows like Grey's Anatomy or ER as a neurosurgery PA, I'm like, they're using like a suction as an intubation tube. Come on. So when you watch these things, is it similar? Like they're just not quite getting it?
I'll take us one step backwards to the question you started with, which is what is autism? And you said it yourself that there are symptoms, and then there is a point where we decided someone meets the diagnosis and then somebody doesn't meet the diagnosis.
Mm-hmm.
So this is the spectrum. So you
Right.
can have different levels of severity. The other thing that I think hides in the word spectrum that is sometimes less highlighted is the fact that there would be a lot of differences even within people that we call those have autism spectrum disorder. There will be a wide range of differences even for someone with the same score as somebody else.
Oh yeah, interesting.
So it's when someone is portraying an individual with autism, probably the dating shows that there
Yeah.
are wide differences in how
Very
they
much,
behave, how they think about relationships, how they react to relationships. And that's what's kind of underneath the concept of spectrum. And when an actor is portraying and somebody with autism, it's probably based on their experience or what they read, and it's a one certain way of doing it. And I'm sure you can find a lot of ways that families who have kids with autism relate to certain behaviors.
Right.
But it has to be exaggerated most times because it is acting and
Minutes for TV.
Yes.
So you were talking about a spectrum, and you hear people nowadays say, like, I have teenagers, and they'll call me and be like, I have this new friend, I think they're on the spectrum. Okay, what does that mean? What is actually the spectrum? What's this part and this part of the spectrum?
The spectrum is broad, and it may not be that important to understand the entire spectrum because we are a medical center and we're thinking about helping people. And somebody who has a little bit of difficulty in language, prosody, how they make their give and take in conversation needs a different level of care than somebody who is nonverbal,
Right.
has intellectual disability, and really has no or minimal adaptive skills, can't navigate the world. So one of the things that really is critically important in autism, and one of the reasons why the TV shows can't really capture it, is that about a quarter to a third of individuals with autism have what we now call profound autism. We made a new term just because people conflate.
Yeah, we're using it too broadly now.
Yeah. And profound autism is defined by somebody who will need 24-hour access to an adult for the rest of their lives.
Right.
And almost certainly have significant intellectual disability, almost certainly have limited or no language, and have poor adaptive skills, poor navigational skills in terms of navigating the world, right? And that is what a medical center tends to focus on. There's plenty to be done. Everybody needs help, and certainly somebody who, is socially awkward, has a little bit of stereotyped
Right.
interests, right? They'll be on TV, they'll be on the show, it'll be very interesting. They have their own lived experience, which is interesting and important, but the kind of help they need is very different than the kind of help somebody needs who has a need for lifelong access to an adult. And actually, we divide the spectrum now into levels 1, 2, and 3. Level 1 is needing some support, or needing support, needing significant support, needing very significant support. And that third tier is where our center is focused on.
Right.
Obviously, there's much to be done for everybody who has needs, and we have a whole program on social skills training or jobs training for people on the spectrum. But that's very different. If you're looking for a job, you probably don't have intellectual disability. You probably have some language.
Right. I think it's probably too freely used nowadays. Like when I'm at night when I'm scrolling Instagram, there might be an ad that comes up with a t-shirt that says, I'm somewhere on the spectrum. It's not very funny. But no, it's a little freely used now.
And I thought when Joe was describing the
Dr. Buxbaum too.
Dr. Buxbaum was describing the spectrum. When we start and we talk about autism, and we say it's genetic, and kind of people think of scientists in white coats sitting in a lab and
we're all black,
measuring something. As you can see, that's not the case. But I think people actually have a very good intuition into what genetics is. They just don't know that it's called genetics. So there are two questions we usually get. One is, hi, I have a brother with autism. I want to have kids. What is the risk for my child to have autism?
Right.
This is genetics.
Yes.
Because people intuitively understand that there is something that is heritable, that runs in families, that increases their chances or potentially increases their chances of having a child or a brother or a sister or a grandchild with autism.
But can you speak even deeper to that? That's actually my next question. Right. Because your research is in the genetics of autism, correct?
Genetics and environmental risk factors.
Okay. So you had started off by saying that genetics is the number one risk for autism, right? So what is there a number associated with that? Back to that person you were just talking about. They're worried if they have kids. What's that number that they need to be worried about?
Fantastic question, really. Because what people usually hear is that autism is heritable, and then they hear a number. And what heritable means is that the risk or the genes that typically cause autism or that could cause autism run in families. That's all that it means. And then they hear a number, 80%, 60%, 50%, 90%. It doesn't matter. It doesn't really matter. For most cancers, for example, the number is much lower. And yet we know that there are genetic causes for cancer. For us, that number means something. It means that we should focus our efforts in finding risk factors or causes more on the genetic side of research than on non-genetic side of research.
Okay.
For families, I think that the important thing is their own intuition. I know that if one child in the family has autism, there is a bigger chance that another child will have it. And I know if my grandson had it and my daughter is about to have a child, there might be a higher risk. I want to know what I should do and how I should handle that. I think that's the difference between scientists getting a number and what this number means.
But can they actually do something? Like if it's genetic, we can't really change your genetics. Well, now. I don't think we can change the genetics now. Hopefully we can in the future.
But
So one thing that comes with the word genetics is everybody thinking that if you have something, it's definitely going to happen. Genetic determination.
Okay.
And there is a type of autism, especially the more severe form, that comes also with a level of genetic determination. If they have some of the more rare causal genetic factors, and I'm using a lot of terms that I didn't want to use, and Joe would be much better at describing it than I am, then they are very likely to have autism. But for the majority of cases, there is a range of a lot of small effects that could accumulate and might cause autism.
Are those the environmental ones that you're talking about?
Well, that's not necessarily environmental.
Okay.
The way to think in the same way that we are thinking of, or we are seeing that genetic factors contribute substantially to the possibility that one person will have autism while another person will not have autism. When we take the natural experiment, which is identical twins, they share everything. They share the in utero environment, they share the growing environment, they have the exact same genes. If one has autism, the chances that the other one will have autism is only 50%, even if they are identical.
Disagree.
Oh, disagree out loud. That's the fun part of this.
It doesn't mean that there would not be other developmental problems, because autism is a very complex disorder. And there is a spectrum, as we said before. So there could be somebody crossing the threshold and somebody not crossing the threshold.
Yeah, you were saying like there's numbers, there's boxes.
Yes.
Somebody's boxes might be different than somebody else's boxes.
So I'm really trying to simplify things in a very difficult topic.
But I think that's an important point, right? Yeah. If we divided the entire population into tall and not tall, I won't look around.
Lesser tall. Lesser tall.
Then, somebody who is 6'5" would be tall, and somebody 5'9" would be not tall, male, and somebody 6'2" would be tall. And we'd say, oh, look, here are two identical twins, and one's not tall and one's tall. Meanwhile, they're both pretty tall.
Right.
And because we have a hard cutoff, especially in research around autism, those twins that are not concordant, that where one has autism and the other one doesn't, it's really, and we know this because we've actually gone back 18 years later and met the twins again. One of them has autism and the other one doesn't, but just misses it by a hair, right? So if we had a quantitative measure, you got a 90, you got an 89, we'd say, oh, they're pretty similar.
So then if you look at their genes, are you going to see a difference?
So with the identical twins, there's effectively no difference. And the difference really is more about the measurement. Remember, we are trying to quantify somebody's social behavior. Do you think we're good at that? Think we can get it like blood pressure?
No,
right. So maybe that person today looks like this and then the next day they look like that.
Right.
But in research, we're very strict and we say, this is different, this is not. Right? Now, if it was height and I said that to you, this person's tall, this one's not, you'd laugh at me.
Right. Well, I laugh at anyone that thinks somebody who's like 6 feet is tall, because to me, you can only be tall over 6'4".
I would leave it.
We're not saying tall is good. There's a song.
We're not.
That.
Of course not. It must come with other risk factors.
But I think Avi's point is very good, that even when people don't share a lot of genetics, don't quite share the trait of autism, they might share a whole bunch of other behavioral things that tend to come together. They might still have challenges in life.
So if that's the case, how do you direct your genetic research if you leave so much to nuance?
It turns out, if I want to understand height, across the spectrum, right, I can actually look at people of any height and measure genetics and say, these are some of the things that are driving you to be more here or more here, without saying tall, not tall, just saying, what is your height, right? And just like height, there are what Avi talked about, these kind of things that add together with small effect, what we call polygenic, genetic variants that, each one has a tiny effect on height, but when you have hundreds of them, you're more likely to be tall versus not tall. That's the polygenic part. But there's also things in height that are major mutations. So dwarfism, Marfan syndrome, where the polygenic nature is still there, but it's not that important. For most people, it's driven by all the things adding together, making you more tall or more short. But if you have certain kinds of dwarfism or certain kinds of genetic forms of very extreme height, like Marfan syndrome, that's caused by a genetic change that has a high effect change. And autism is the same way. We have things that are major effect genes and things that are polygenic, that we all have some of those genes, right?
And you were saying that Mount Sinai generally focuses on, you said profound autism is the diagnosis that we use now, profound?
We are actually one of the few sites that have always focused on profound autism, not exclusively, but for many years, research was never done in profound autism because it's much harder to do. You can't ask questions if somebody's nonverbal. You can't even do imaging studies if they're not able to sit still and listen to instructions. And so when I came into the field, everything we thought we knew about the neuroscience of autism were people who, over 18, volunteered to go, to join the study, were given a complicated task in a scanner, and they had autism, but they didn't really tell us much about anybody who couldn't consent, who couldn't do a complicated task in an MRI scanner, and then answer questions before and after. And so we decided to figure out how to also work with profound autism, but it's also where the greatest need is. So we tend to focus at Sinai on profound autism because we actually think that's where the greatest need is. And we have treatments already, the field, for people that have less severe, their level of need is much lower.
So what is that? So I would imagine that if you have profound autism, what's the age that one would be noticing that generally?
An expert site can see autism emerging by 18 months.
Okay.
Now, the profound autism is often coming with other things.
Right.
Language delay, motor abnormalities, intellectual cognitive delays. And so you actually often see things even before 18 months. They're missing milestones of development.
So how long do you follow those patients for? Like, what's the difference between treating like adolescents with autism versus adults? Because I would imagine, someone who's been there all along has been getting that treatment. But now there's people that are getting diagnosed as adults. Are you guys seeing those people too and treating them?
It's important to know or to remember. It's important to remember that, as you said, people get a diagnosis at a very early age. And the more severe the cases, I think the earlier it is being noticed, especially in the recent decade. People are more educated, clinicians are more educated, they're more aware. They're looking for kids who have difficulty developing, and so they're being diagnosed much earlier. But individuals receive a diagnosis of autism all through adolescence and all through early adulthood, and sometimes even after early adulthood. Part of it is because there was an awareness for that kind of a condition in 10, 20, or 30 years ago. And with that came the concept of the spectrum, because those who were less severe, those who had other coping mechanisms, those who had other disorders that are as severe as their autism or spectrum autism, received other diagnoses, were able to function, and so they get a diagnosis a lot later.
Right.
Does it make necessarily a difference or a need for them to be treated? Not to all of them. Some of them just want to know that they have it, and okay, I make peace with that. Now I have an explanation of what that explains a lot of things that happen to me. Some would like to receive treatments that help in social communication and
what are those treatments?
Joe?
Yeah, so the treatments, if you will, are behavioral, right? So it can be
CBT, cognitive behavioral therapy.
It could be that, right?
Okay.
But if you are, if you've been diagnosed in your 20s with autism and you've kind of been navigating life well, but you have challenges, then often what's going to happen is you're going to address the challenges. I have difficulties in social situations. And you can actually be trained to do better, to be able to, take a pause, give somebody else a chance to talk. I haven't learned that myself, but someday, making eye contact, you can actually, there are social skills training groups that will actually help you do that more smoothly. We do something about job interviews. That first impression is important. You can be the greatest person for the job, but if you kind of come on too heavy or you're kind of disengaged, you may not get the job that's actually perfect for you. And so jobs training says, okay, we're going to walk you through this process where, for some people it's natural, for some people it's less natural, and we'll help you navigate this problem. So I think all of what we do is
I feel like that should be in every school system for everyone.
Yes.
All these kids are like stuck on their phones and don't even know how to have face-to-face conversations. There should be social norms classes.
In a few years, the kids with autism spectrum disorder
are going to be doing better.
Better. Yes, exactly.
So that's one form of treatment, if you will, but it's directed at crafting skills, developing skills, and maybe if you're younger, changing behaviors, right? The ABA-based approaches.
What about I know that for people who get nervous in situations or public speaking, you can take beta blockers or anxiolytics. Is that something that's utilized?
Again, and people that have minimal needs, they also have the usual spectrum of anxiety and maybe ADHD.
So just treat as normal.
Treat as normal. Yeah.
Okay.
Treat as
I understand. So from a public health perspective, access to care is important, right? So I guess we're going back more towards the higher end of the spectrum now. There are some conditions that choose communities that typically have poor access to care. Does this have a socioeconomic class that it tends to go to, or is this just everyone? And are people who need the care getting the care?
So that's the easy one. The easy is no. So we think that autism, and again, because it is so heavily genetically loaded, it doesn't really care about your socioeconomic status. The level of care you get completely depends on that. Mm-hmm. Even when how old you are when you're diagnosed is directly related to access and socioeconomic status.
Like, are these the treatments for younger people? Are these covered by Medicaid?
So it's a complicated thing. There's a lot of state involvement. Some states are better than others. And then, it's
called like early learning intervention. What's that called? The early learning that you can have your child evaluated?
So just
you guys are like, I don't know, they just show up. That's all I know. Okay.
Educate the EIPs?
Yeah, there's evaluations that you can have the state do on your child.
Correct. So EIP will say, this is the kind of
early intervention, yeah.
Yeah, this is the kind of thing that this child will need to be successful, right? So you can have that done. It's very hard to get done if you don't have access, if you don't have pull. It may take a long time. If you're in an under-resourced school, it may take a long time. If you're in a county that doesn't take it seriously, the reason people with autism in their family move different places throughout the country is often to get better access, if they have the resources to do that.
Yeah, my son in like second or third grade had some difficulty in school, his attention span, low tone, and I went through the early intervention and just filling out the paperwork, coordinating all of that and getting them to the right sites. I wanted to give up. I was like, this is ridiculous. I can't imagine how somebody with less means than me would do that. Yeah. So we talked a lot about the behavioral treatments. What about pharmacological treatments for this?
Yeah. So we really don't have any drugs today that address the core symptoms of autism. But as we find more genes that actually are these high-risk genes, that if you have a mutation, you have this kind of what Avi called genetic determinism, where you're very likely to have very significant developmental delay issues, that gene itself becomes a target for drugs. Because in that person, it accounts for most of the risk. And so there are many, many academic sites and many companies now that are beginning to try and target these genetic causes of autism. And the first studies that have come out in Angelman syndrome and Fragile X syndrome have seen improvements in language, cognition, daily living skills, which, as Avi also intimated, these are often much more impactful than the autism diagnosis. Many families say it's not the autism, right? My kid never sleeps, it's not the autism. My kid's not toilet trained, it's not the autism. My kid has very severe intellectual disability. Fix that and we'll talk about the autism next.
So when can you use these potential treatments? Is that something that they have to be alive? Is this something you learn on amniocentesis? Where are we?
So the treatments are just emerging and they're still in. The FDA has just approved phase 3 trials for the two that I just mentioned. So we don't even have the final results yet, but the results so far look really good. The testing is easy. You can test anybody at any time for a specific genetic change. If you want to say, does this child have Fragile X syndrome? Does this adult have Fragile X syndrome? We can test that tomorrow, right? So it's about testing for a specific treatment. And only when we have treatments that really work will people begin to test. Yeah.
You talked about the comorbidities that they often have things that, like one of the things that we hear a lot about is epilepsy. How often is epilepsy presenting with autism or vice versa? Epilepsy is seizure disorder, just so you know. It's the brain abnormally firing, which leads to seizures.
Again, it depends on severity. Yeah. Certainly, as you go to the more severe, the greater level 3 requires more support. Epilepsy is more common, 30%, 40%. And some disorders, it could be even higher than that. And it's quite debilitating.
What's the pathophysiology of that? Why is that? How?
So let me ask you, as a neurosurgery PA, what links together social deficits, cognitive deficits, language delay, motor abnormalities?
Well, you're looking for a part of the brain. The amygdala? Well, I mean, across the midline, the corpus callosum.
Yeah, so it's some developmental brain process that turns out to affect a lot of things at once. It's pretty rare. I would almost say by definition, if somebody has level 3 autism or profound autism, and they have intellectual disability and limited language, a lot's going on, right? Yeah. And within that developmental trajectory of the brain where, there are issues during the actual development of the brain and the function of the brain, epilepsy is not that surprising in that
Right.
context, right?
So the brain's just not firing the way that it should.
Right. We think of epilepsy, people talk about the balance of excitatory and inhibitory nerves. In behavior, everything is a balance between excitatory and inhibitory. That's how we function. But we think of epilepsy as being, that you're kind of, this concept of canalization, where the brain develops this way typically, but maybe it jumps and you develop a little bit differently. And that brings in a burden of other disorders: epilepsy, intellectual disability, language delay, motor abnormalities, and autism.
So then the epilepsy in that situation is treated just like any other comorbidities, treated as it comes.
But it sometimes doesn't respond well to treatment.
Right.
And so there is also the hope that if we can go back to the fundamental causes of that autism, the epilepsy may also get better.
So how far away do you think we are from that genetic manipulation, the pharmacogenetic treatment that you were talking about?
In Angelman syndrome, there are three trials approved by the FDA for this year to do pivotal trials. Angelman syndrome is a genetic condition with very high risk for autism and developmental delay. It has certain characteristics that make it a little bit more tractable for genetic interventions, for genetic gene-based therapeutics, and that's why we see 3 companies coming out at the same time. I think we're there. I think in the next couple of years, there's going to be some breakthrough findings that are only going to address a small fraction of autism. But imagine once we see that happening, somebody, maybe that they don't even have autism. Maybe they just have intellectual disability and no language. They start getting better.
Yeah. Then
the lemmings in pharma, who will never do anything first, who will never take the first step, who always want to be rapid adopters, right, will say, oh my God, we can actually make a difference for people with real significant developmental delay burden, and they'll start to get involved. So I think our role in academia is to take these risks that, somebody who's kind of beholden to their shareholders can't do, which is actually try and help people that are, maybe it is just a small percentage of everybody with autism, but if we can make that better, everybody will jump in and try and help everybody with autism.
Yeah. Well, do you want to add to that?
I just wanted to say that the start would probably come from the treatment of rare disorders. We are still far from a GP1-like medication in autism.
Right.
So for anyone listening, and once the news come out and there might be a drug and think, oh, this could work with my kid, it might not, because it will be targeting a very specific population. I thought of also adding a little bit to what Joe was mentioning about the fact that individuals with autism, especially with a more severe form of autism, have multiple developmental difficulties, or different disorders. And for us, one of the question is, why do they have multiple disorders? And is it the same thing that causes all of them? Or is it different things that happen to occur in one unlucky individual at the same time? And I don't have a good answer for it. But
well, in medicine, you're supposed to choose the former. Things are
maybe.
Yeah.
Where is the one that will hit?
You're supposed to pick that
what
one
is the
thing.
silver bullet that will hit the right one, and then everything will unfold? So most of what we think right now is that there is some overlap in terms of the genetic of all of these disorders. But we might be wrong. So
right. I guess we'll find
see.
out.
Yeah.
One of the biggest misconceptions out there, and I can say misconceptions because I'm educated to know it's not, is that vaccines cause autism. But that is not true.
No,
that's been debunked over and over.
Vaccines do not cause autism.
So why do we know that? I want people to hear this. Why do we know that vaccines don't cause autism?
Well, dozens of studies which specifically looked at this question. Do vaccines increase the risk for autism? Definitely not cause autism. They don't. The best researchers in the field and in other fields have looked at it and ruled out an association between receiving a vaccine and triggering autism.
Okay.
It simply doesn't go hand in hand.
Okay. Want to add anything to that?
Yeah, and there's also been somewhat of a moving target, right? Many years ago, it was the preservative in the vaccine, the thimerosal, that caused autism, until somebody got up and said, well, Canada has stopped using thimerosal for many years. What is the difference in rate between Canada and America, and there was no difference. We stopped using it in America, and then they said, well, it's the adjuvant, right? So there's a bit of a moving target, but writ large, if you look at vaccines and autism, there's been not only no evidence, but there's been so much negative evidence, right? You can't prove a negative, unfortunately, right? There's always, is there one person somewhere who might, you can't prove that that's not the case. But this has been studied so extensively on huge scale, national level scale studies that continually refute the relationship between vaccines and autism. And it just is puzzling why it persists in spite
For the
of
same
that.
reason lots of things persist with people. They just get stuck on it. I was talking with my father about this before coming here today, and he was explaining to me that, I don't know when, maybe it was like 2 decades ago, school systems would get reimbursed for any child that was diagnosed with autism. And he said that's probably one of the reasons autism started to increase. It was just overdiagnosis. So over the last several decades, there has been an increase in the diagnosis. Is there something more nefarious going on? Was he just undiagnosed before? What do we think that causes?
I think we know some of the causes, and I think we know all of them, but maybe not. One is that the diagnosis has changed dramatically. It's much broader than it ever was before. When Leo Kanner in the 40s defined autism at Johns Hopkins University, he talked about kids that he could see at 4 and 5 and 6 months of age were different. They weren't reaching up for mom or dad to pick them up, which is a built-in innate reflex we typically have. And so he talked about that kind of autism. That is like ultra profound autism, if you will. That's not our criteria now. Most people with autism are, they hug and when mom reaches down or dad, they put up their hands, right?
So it's just a more inclusive diagnosis.
It's a much bigger, broader diagnosis. There's much more self-diagnosis. So the neurodiverse community might talk about themselves as opposed to a clinical diagnosis. We're much better at finding people with autism. In the past, we might have said, this person is in a home. I mean, there have been studies going around in the UK, different age groups, that's 50-year-old, 60-year-old, trying to find everybody in a county who is 50 years old and asking, with today's criteria, would they meet criteria for autism? And the answer is yes, and it's about 1% all the way through the age group, right? So in the 60s, that person might have been told, parents might have been told, child's not going to go to school, they have to be institutionalized, and they weren't given a diagnosis of autism, but they could have been using modern criteria. So those things by themselves are major drivers. And as you also said, having a diagnosis of autism actually gets you services that you don't get for other diagnoses. And those services are important whether or not you absolutely meet criteria for autism or not. And so it's almost compassionate for some clinicians to say that autism diagnosis, they get services guaranteed by the state.
That's really meaningful. That's a really big deal. Do you want to add to that?
I thought you used the perfect term to describe what we are seeing. So you said that people who are registered to have autism, the numbers have gone up over time.
Right.
What we are seeing is that when you're using the same diagnostic criteria in a standard setup, it looks like the symptoms are at the same level throughout decades. It's just whether they're being diagnosed, they're being referred to the right services, the right services are available for them to be referred to. Mm-hmm. If there was any increase, the real increase would be very, very, very small.
I think that's probably one of the most important things you guys said today, that this rise of diagnosis is just that, the diagnosis of it, not necessarily the true incidence of it or prevalence.
Because we don't think the causes have changed.
Yeah, okay.
But also people have gone back in time, and said, okay, let's apply today's criteria on, and they say it hasn't changed. Yeah.
I want to talk about another word, because we talk about the term on the spectrum. What does the term neurodiversity mean?
It's a wonderful word, and I think it's what people talk about typically themselves or their peers who are, different. They're diverse, and that's a wonderful thing, right? When we talk about a disorder, it doesn't mean that it's bad. I could be neurodiverse and prone towards, OCD, right? But if it interferes with my life and my functioning, I might get help for that OCD. But if it just helps me in my job because I am a project manager, I'm super organized, I love things that I may not seek out help.
Or you're quirky and fun to hang out with.
Right.
Maybe that's it.
So
So neurodiverse isn't bad. It's just,
Correct.
it's basically being just different.
Yes. Now, what's happened, unfortunately, is that because we use a single term to cover all of this, somebody who's neurodiverse hears me talking about gene therapy and they say, why do I need that? And the answer is they don't,
Right.
right? They are living life. They're the life of the party. They're quirky and fun to hang out with, right? They may have troubles that we all have. They maybe get some depressed episodes and want to get treatment. But when we're talking the value of separating autism into its kind of severity spectrum and the comorbidities is that a lot of people confuse neurodiversity or
The term. Yeah.
the concept with, hey, we really need to get in there and help this person because they're really suffering.
Right. Actually, that's a really interesting concept. My son has ADD, and before he was medicated years ago, was just, very difficult to get stuff done. On the medication, he's great, but also on the medication, he's not his like crazy fun self. So he has to pick and choose the time he wants to take it and what's happening that day because he wants to be, he embraces that side of him.
Yeah, and that
same
is
thing.
embracing neurodiversity, right? But the moment, is he's not an adult yet.
He's 19. He's an adult.
Okay, he's an adult, right? So, but at some point in his life, as an adult, or even in conversations with his parents when he's younger, he could say, "This is what I want to do, and this is what I don't want to do."
Right.
Right, and that's perfectly fine.
Yeah.
Right.
There were many times this summer I was like, please take your medication. He's like, nah, not today. Today I'm going to do. Yeah. We talked about vaccines. Is there any other, I feel like maybe Tylenol I've heard about. What should we know about Tylenol?
So Tylenol, again, people have looked into it very carefully. In Sweden, there was a major study in Sweden. There's just a new paper coming out in Japan. These are very large studies with many, many, many moms taking Tylenol during pregnancy. And all the evidence is that there is no contribution of Tylenol to autism.
Okay.
Now, one of the problems with all these kinds of studies is mom took Tylenol for a reason, right? And fever is often the reason. And fever by itself probably has risks for developmental outcomes in their child, right? So if you control for the indication for why mom took Tylenol, it definitely goes away, the association. But even the association itself is effectively non-existent if you control for other variables. So one of the things that Avi's led in the world is showing that there are medications that mom takes during pregnancy that are associated with greater risk for autism in the child, but it's not the medication. Mom had to take an anti-epilepsy drug during pregnancy, even though we always try and get moms off of it, because her epilepsy is so severe that she had to take it. Severe epilepsy shares a lot of the genetic risk as it does for autism, as you said before, right? So if you say, not mom took this anti-epileptic and therefore it caused autism, but mom had epilepsy, yes, the child is at increased risk for autism and for epilepsy too.
Right. Yeah.
And again, we get to the point of what is risk. We go back to the point of what is risk versus something that is determined. So risk only means that there is a higher chances that you will have it. It doesn't mean
Not
that
a
you
guarantee.
necessarily will have it. So
Right.
any decision that is done by a pregnant woman about taking or not taking medication should take into account a lot of factors and should be done in consultation with the treating physicians that they have.
What exciting things are happening at the Seaver Autism Center that you want to share with us here at Mount Sinai?
So we are very privileged at the Seaver Autism Center to be one of the leaders of an international endeavor to find these autism genes. And we've been very successful. We've found over 250 genes that clearly contribute significantly to autism risk. And for about 10 or 20 of those genes, we and others are beginning to think about therapies that actually target the gene mutation. And that is really the most exciting thing. It's what we talked about before, some of these clinical trials that are coming out. And the Seaver Center is a leader in these clinical trials and will probably continue to kind of grow as one of the lead sites for actually finding the genes, developing therapies from the genes, and then starting to try treatment trials for those genes.
That is exciting.
We are doing what is probably the largest study so far, examining the range of medication mothers take during pregnancy. So you heard before about taking medications
Right.
for epilepsy and whether it is a risk factor or not. There was a lot of literature also about antidepressants and risk for autism, but the overwhelming majority of medications pregnant mothers get or take have never been studied in relation to autism. So the Seaver Center team is also mapping those relationships, trying to do it carefully with everything we know about confounding and statistical control and replications to make sure that whatever we see, we are very confident that is real. And we have to keep in mind that we might also find some things that are protective.
Right.
So we are hoping that we might see some things that increase the risk, but maybe we'll see some things that decrease the risk and can be then used in parallel to other treatments.
Okay. Well, as we close out, if you guys don't mind both sharing 2 things that you wish everybody knew about autism.
Don't be afraid of vaccines.
Right.
And genetic risk is not genetic determination.
Right. So that means just because
you have the
genes doesn't mean you're going to get it.
Absolutely necessarily will have a disease.
What about you?
I think it's very important that people appreciate what we mean by spectrum and that there is profound autism, which is not represented on TV typically. I think that's critically important. It helps us kind of conceptualize what we're doing and people understand it better. And I think it's also very important for people who are touched by profound autism to know that there are these breakthrough treatments that are happening right now that are going to change, really, I believe, change the world. When we see these things, we can intervene on somebody with, profound issues and watch them get better quickly.
That's amazing.
I think that's pretty amazing.
So thank you guys so much for joining today. I appreciate both of you being here, and I definitely learned a lot. So I know our listeners will too. That's it for this episode of The Vitals. I'm your host, Leslie Schlachter. Subscribe to The Vitals and Mount Sinai's other podcasts on YouTube, and find us on Apple Podcasts, Spotify, or wherever you get your podcasts. To learn more about the Seaver Autism Center and Mount Sinai's groundbreaking autism research and treatment, scan the QR code on your screen and click the link in the description below.